All right, we'll go ahead and get started. We've got a wonderful hour planned for you today. We've got a three-person panel that's going to talk to you about combination elements and models of integrated care with a focus on how collaborative care may relate to that. Myself and Tisha and Monaco tried to choose individuals with various backgrounds and kind of different experiences in the integrated care and CoCM space. I'll have our three panelists introduce themselves. Can you share for the group your name, your integrated care role, and just kind of a brief description of the services that you offer, whether it's like population or care reach, or what you're using in terms of integrated care to include but not limited to integrated care. And we can start with Cody.
Hey, thanks. So I'm Cody Hostutler. I'm a psychologist that works at Nationwide Children's Hospital and the Ohio State University. So I spend 2 days a week in clinic, and then the rest of my time as the clinical director for behavioral health integration. And so internally, we run kind of a pediatric PCBH model, and then simultaneously we run a co-located model, and then we have a psychiatric consultation line that supports us when we have medication needs. And so we have that internally, and then through a partnership with our accountable care organization, we're working on scaling models of integration across the state as well. So we do a lot of technical assistance and consultation for the state to get integrated care kind of scaled across the state. Was that everything, Laura? Yeah.
That's great. Thanks so much. And next we'll go to Beth.
All right. Hi, I'm Beth Zeidler Schreiter. I am the Chief Behavioral Health Officer at Access Community Health Centers. So we are a federally qualified health center that has 3 medical, dental, behavioral health integrated sites in the Madison, Wisconsin area. I do clinical work about 20% of my time. The other 80% of my time is administrative and leadership. I'm a senior leader at Access Community Health Center, which is a really important piece when we think about behavioral health being integrated all the way at the top. So as we're thinking about changes and systems, and whenever we hire a new medical provider, it's what does that mean, right, for additional behavioral health? So to have a seat at that table is huge. And Access has been a long adopter of PCBH. So that started in 2006. Started out with a psychologist of one who was Neftali Serrano, who hired me. And then we have continued to grow. So we actually now have 12 BHCs. We have 2 behavioral health care coordinators. And then we also have a consulting psychiatrist. Dr. Julie Nielsen, unfortunately, was unable to join us today. So I'm going to channel her in this as well. But starting last August of 2023, we also went live with a CoCM program. And so we are an organization that is using both PCBH and CoCM. And one of the things that makes the way we're doing CoCM a little bit different is our care managers are called BHCCs, or behavioral health care coordinators, and they are both bachelor's trained. And so we have 2 of those, but because we have the robust support of the BHCs of being the licensed clinical social workers and psychologists, it's been really wonderful to be able to leverage both models and give our patients, I think, choice and opportunity related to the level of care they need to support their wellness.
Awesome. So as you can see, we've got some evolving differences with populations, with care elements. This is going to make for a really rich discussion. We have our third panelist today, Janine. Can you introduce yourself?
Hi, everybody. My name is Janine Fonfara. I work in Connecticut. I have an LCSW. I've been an LCSW for 35 years. And about 10 years ago or so, I went back for my doctorate in behavioral health integration. And about 15 years ago, started the integration program at Hartford Healthcare, where we were doing only PCBH at that time in primary care practices and family medicine practices, as well as specialty care practices. That still exists today in Hartford Healthcare. And probably about 7 years ago or so, actually I see Lori Rainey's on the call. Lori came out to Hartford Healthcare to train our organization in how to implement collaborative care management. And Hartford was slow on the uptake of CoCM, mostly because at that time they were really kind of satisfied with what PCBH was available to do at that particular point. Now they're in the process of moving more in depth with CoCM in Hartford Healthcare. That said, about 2 years ago, I left Hartford and I joined Middlesex Healthcare in Middletown, Connecticut. And when I was hired on to do both clinical work to get started again. So about 20% of my time is clinical work. And the rest of my time is administrative so we've just put 3 behavioral health clinicians into our family medicine practices here. And we would like to do the blended model in those 3 family medicine practices. Right now, the organization contracts outside of the organization for CoCM work in the primary care practices. And that's something that we'd like to explore more. How much of that can we be doing in-house and should we be doing in-house in care of our own patient population? So it's been quite an experience of learning along the way and working with various age groups, various comorbidities, and various providers as well. And so that's part of what I was hoping to also talk about today, is bringing on bachelor's level consultants next, because I do think that that's where this needs to go next in this organization. Thank you.
Awesome. And one of our panelists can talk about that piece. So kind of with that in mind, we've got different people at different stages of collaborative care implementation. Everybody with, a longitudinal history with integrated care. The next question I have, and I'm going to start with Beth on this one. What role do you see collaborative care model offering or not offering your care delivery model at this point?
That's a great question, Laura. And, for me, I grew up in PCBH, and so the piece around the generalist and accepting of anything and everything has been huge for us. However, we weren't able to really follow to the degree we wanted, right, of treat to target for patients that had depression and anxiety. And so for us to be able to have this systematic, registry-driven, proactive outreach to keep people engaged in their care has been huge. It's been really well received by our patient population, but it's also given choice, I think, to our patients. It was interesting. I saw on the listserv, right, the questions around what do you do when you screen somebody and you spend the time and then they don't fit into CoCM. And so one of the ways that we've set this up is that our PCPs still refer to BHC always. Like, we are still the entry point. And we did that intentionally because we didn't want them to have to be this decision maker, because they're already just doing decision, overload all the time. And we know burnout is real, that we wanted them to do what they've always done, which is refer to your friendly neighborhood BHC. And then what we're doing is we're meeting with the individual and we're clinically assessing, like making sure there's a diagnosis, right, that fits into the registry. We're making sure the PHQ is administered. And then we're talking about, is that somebody we think would be a good fit? And when that's the case, we're sending it on to the behavioral health care coordinator, who then is outreaching and setting up, the initial connection point and starting, to track time and all of that through CoCM. And so it really has been a really seamless process for us to be able to connect people that are appropriate and motivated, right, for that level of contact and touches. But then to make sure that the people that maybe don't fit based on the registry criteria, that we have an offering for that too. And that has been just really helpful. It's been a satisfier for our medical providers, but it's also been a satisfier for the care team as a whole. As the chief behavioral health officer, I'm also the one though who reports on all the metrics, and that's our depression screening. What are the levels of intervention for depression, and then now the new metric around remission, right? And so I was like, this area we have opportunity for improvement, and so I was really excited for CoCM to really help us with some of those core metrics. And for us, it's having both models to be able to really align with the population of a community health center. That has been so helpful for us. But I think it's been easier for our providers to adopt this because we haven't done a ton of change in how they interface with integrated care. It's been more of we're kind of doing that piece for them. We also kind of rolled out the CoCM work alongside with our psychiatric e-consults at the same time. And that has been huge because as a community health center, we're actually getting reimbursed at our PPS rate, which is the prospective payment system, for the written consultations that are done by Dr. Nielsen. And so it's really about how we're advocating, I think, at a state level to get compensated for the work that we do every day to support population health, right, and whole person health. So this has just been a really exciting time. I also neglected when I introduced myself to share that I am a professor through the Department of Family Medicine and Community Health at the University of Wisconsin. And we do have a family medicine residency training site, and that has been huge. And we actually have hired many of our primary care providers out of that residency because they want to go work on their career ongoing at a place that has integrated care. And so I think that's another piece to be able to use when we're talking about selling the importance of integrated behavioral health at an organizational level, is it's a recruitment retention tool and ways to provide optimal patient care, but also to support the care team well-being.
You outlined some really outstanding ways that you've used combination elements and models to fill that, whole person, that population health approach. And it really showcases how we can complementarily do that with the different models. They don't have to be competing, but we have to be thoughtful about that, and kind of building that off of a foundation of PCBH has been a really natural way, it sounds like, to have CoCM fit nicely. Janine, let's have you answer this question next. I know you had shared that you're kind of in the early stages with some of the new pieces with the family medicine, but would love to kind of hear, especially with your work previously with Lori and kind of the evolution, how CoCM is fit and not fit into the different experiences you've had with integrated care.
Sure. So just to piggyback on what Beth just said, one of the ACGME requirements now for residency programs is that the residents are being trained in integrated practices, which is just terrific, And so that's supporting the work that we all here are trying to do. Even now, so after this meeting today at 3 o'clock, we will have clinical consultation with our psychiatrist, and we use a registry. So even though we're not doing CoCM yet, as far as our billing and our et cetera, that's in the process of being worked out. We're still working the model right now until we can get it up and running through Epic, et cetera, and that, I think, speaks to just how important it is. The primary care providers to have that consultation from the psychiatrist is really key. And then, to be able to think about when are we doing 90791s, 90834s, traditional psychotherapy codes, which we do in our family medicine and primary care offices. And then when are we going to do our CoCM work? And so, but I will tell you the other really kind of creative thing we did at Hartford, and when Lori was there, we not only did we have LCSWs working with psychiatry and MSWs working with psychiatry, but we brought on a CODA. And so not an occupational therapist, but a certified occupational therapy assistant. And I will tell you, she is phenomenal. And occupational therapists have this really great knowledge base of head to toe on a person and the behaviors and the reasons behind certain behaviors. And especially if it's someone who has a lot of experience already in the field, CODA, we have found, is a nice addition to the care team. So I guess, what I'm thinking of here, as far as this small community organization, small community hospital compared to where I was, which is an extremely large healthcare organization. Even here, we have a really wonderful mental health clinic that one would say, oh, we should be able to easily refer a patient from our primary care location over to our mental health clinic, and they should be able to get in relatively quickly for longer term psychotherapy. It doesn't happen. So, there's no openings anywhere. And so that's that balance that happens all the time, though, in the primary care location, is making sure that our input valve and our outflow valve is as even as it can possibly be, because otherwise clinicians in the practices will just get bogged down with psychotherapy sessions, and then you become a clinic within a clinic, and that is definitely not what we want to be doing. So all the more reason where collaborative care really fits in to that model.
I love the examples you highlighted of sort of the elements and approaches you've been able to incorporate, and then also the barriers. You mentioned the billing piece. How do we capture the work that's being done both accurately clinically and then also within the parameters of what we're working with? That's something that's come up multiple times in these conversations about combination elements. Cody, can you share your answers to this question? In what ways, what role do you say collaborative care model offering or not offering your care delivery model?
Yeah, absolutely. So, like I said at the start, we work primarily with peds, being a children's hospital, and so there's really three ways that we've incorporated some CoCM concepts or the CoCM model within our work. The first is through kind of our regular pathways or routine pathways in PCBH. So, for example, we've built out our depression pathway within our PCBH model by pulling in a lot of the CoCM components, things like having a registry for those patients who are on that pathway, having disease managers is what we call them, because they originally started with asthma and they select certain disease populations. There's some, mixed feelings once we started moving into mental health with keeping the name, but they're essentially care managers who are involved with our depression pathway, who are doing outreach, who are calling the families, supporting them, coming to visits, checking in on their homework that they were assigned, their therapy homework, as well as the medication adherence and MedRec and updating the registry and updating their symptoms and treatment to target within those pathways. So we've really pulled in a lot of the components of CoCM within our specific pathways, without it necessarily being overseen by a psychiatrist. I think that's the part that we've kind of left off of the model, and leaving our psychiatrists to be as needed consultants when the team determines a need, when they're not making progress on team review within the registry. And largely because most of our clinics are staffed by a psychologist and sometimes a master's level person as well. So we just didn't think that extra layer of oversight was needed. So we've pulled in a lot of those core components and concepts within our routine pathways internally. The other thing is we are expanding. In Ohio, we call them QBHCs, but we're expanding our approach to using more bachelor's level folks within our model. And we do think the structure of the supervision that exists within CoCM is a really nice fit for expanding and thinking about how we expand our workforce, as well as defining a specific population where we can make sure that those folks are really trained up in those key skills. And then the third place that we've leaned on CoCM a little bit more heavily is when we expand out into the more scaling integration through the Appalachian section of Ohio, where providers are really hard to come by. Oftentimes finding an independently licensed provider is very difficult. And when you do, they're often running the community mental health agency. They're not working, full-time in clinic. And so the ability to have a little bit more flexibility in who that behavioral health clinician can be in the collaborative care model with the supervision and some of those quality checks that are incorporated, it has been helpful as we've expanded out into these areas where the workforce just doesn't quite exist to support some of these other models. So that's kind of the three ways that we've used it, both internally as well as within our scaling framework.
What I love about those examples is it shows how we can bring in these elements of collaborative care without the full model. What Diane Powers, what you had posted in Basecamp about, we've got limited evidence base to really catch up to what's going on clinically and practically out in the field. There is these opportunities to apply elements that apply to the population based upon resources and needs that, your example really highlights the ways that can fruitfully help your population. For our next question, and for this one, let's start with you, Janine, for this. What have been the top challenges and successes you have experienced delivering integrated care through a combination element approach?
Well, what I would say has been actually one of the biggest challenges has been when the best way to say this, I guess, is stigma still exists. That's been the greatest challenge. And what I mean by that is, you know, even with the requirements from ACGME that residency practices are fully integrated, we are still seen as a program within a practice, as opposed to we are practicing integrated healthcare going forward. And so the messaging is always, you know, if you had any other provider who was starting to work in your office, how would you support that provider? You know, there are times that they want our clinicians to be working their own referral work queues, or, you know, managing certain administrative responsibilities. Not to say that we're opposed to that, right? Because social work, there's an element of that in social work, but it's still, this part of the body still remains, we're just not fully there yet. That's, you know, the holistic care is still not there. And this helps a lot. It's moving us all at least onto the same playing field. And that's a really big deal, especially for those of us who've been in the field for a long time, because you know, certainly my experience is a lot of separation in mind and body care. So anything that brings us back, brings us into the fold is very, very important for us, I think, as a group of people to continue to be moving forward. I don't know if that really answered your full question, but that's kind of what comes to mind at the moment.
I think it did, you know, this idea of integration being both the challenge as well as the success. This idea that we're not co-located referral-based care, but that traditional model or that traditional experience still exists, is both the challenge as well as the success. So I like how you kind of interlaid the different layers of how that's kind of playing out in your care experiences. Cody, can you take this question next?
Yeah, I think one of the challenging things when you start stacking the different models together too is making sure that hierarchies don't develop within them too. You know, in our model, we have psychologists predominantly running the PCBH model, highly integrated. About 70% of our patient contacts are team-based contacts with the physicians on the physician's schedule. And then we have master's level folks who are doing a predominantly co-located type of model. There's a little bit of an overlap there, so they definitely step in and take warm handoffs and joint visits when we're wrapped up and we're kind of drowning a little bit, or if it's a patient they have a strong relationship with, they're often jumping in and doing those team-based visits. But it's basically, you know, like a 15% integrated for our co-located therapists, where it's about 75% integrated for our psychologists. And you know, with those difference in degrees and then the different models, there starts to, I think, if you're not careful, there can start to be a little bit of a hierarchy that starts to feel like it gets developed there, and I think that can be challenging. And then and then when you involve psychiatry, where is that in the hierarchy? And I think just making sure that we're truly being collaborative and team-based, while also then defining roles, because I've also consulted with practices where master's level providers are saying, we're literally doing the exact same job as the psychologist. Why are we getting paid less? Just because we didn't go to school as long. But honestly, we're doing the same job in the clinic. So why is there a pay differential? And so I think making sure that people have clear roles, that we understand the strengths of each individual profession, and that those roles, if there are pay differences, that they're understood by everybody, and that it's collaborative and team-based. And that's kind of a dialectic, right? It's both that sometimes there are differentials in pay scales and responsibilities, and at the same time, we want to make sure that everybody's collaborating and that everybody's voice is valued. You know, we're an all teach, all learn clinic all the time. So we always say, look, if you're a reg person and you have insight into this family, you have just as much of a voice as the physician does in this conversation, right? We're all teach, all learn. We're all caring for kids. We all have an important role to play. So it's managing, I think, that dialectic of those hierarchies that might start to get established, as well as making sure that roles are defined. And if there are different structures, that those are justified and those are kind of clear and self-evident as well.
Outstanding. You know, this piece of our spirit of the clinic, all teach, all learn, And then also needing to make sure we have clear like outlines of the boundaries, but then also not having that hierarchy develop, which is natural in medicine. It's really been built that way. So kind of fighting as well as leaning into the different elements that we have at play in that setting. Beth, why don't you round us out with that question?
Great question. And I do think that for us, like one of the biggest challenges for me was just learning about CoCM, right? Because it was like we were doing this PCBH model and I was like, that I know, right? That I know and that I know well. This is what the model I grew up in. And so CoCM was this opportunity of like, oh yeah, this is a whole nother way, right? That we can use this. And, I've been at Access for 15 years. There was a time where these models felt competing in a way they never needed to, right? So I also think that we're in a different place, even amongst those on this call, right? Even amongst within CFHA, that we're really able to say, like, this isn't a turf war. This isn't about who can do it better. It's about what are the needs of your population and how are you leveraging these models to do it the best to your ability, right? So I think honestly, that's been a challenge that we've overcome, right? As I think a team of interdisciplinary professionals, and that is really cool to see. But while we had this amazing PCBH foundation, it was a steep learning curve for myself, for my primary care behavioral health manager that oversees our care managers, and Dr. Nielsen, who's our consulting psychiatrist, isn't here, but it was leveraging her in a different way, right? So she's always been a consultant within family practice. And so Access was unique in that we were doing kind of a PCBH plus, right? Because PCBH historically hasn't had a psychiatry component. We've had consulting psychiatry from the beginning. And our consulting psychiatrist, though, would do one-time consults, and she still does. And she makes written recommendations. She does the e-consult. But then she's also wearing this other hat, right, as the collaborative care psychiatrist. And she's doing a lot of education and training with our care managers and our BHCC position. And I know there was a question, and I tried to reply about some of the challenges, right, with having a bachelor's trained care manager. And I think there's tons of benefit. And the challenge or opportunity was there needs to be more training, right, around motivational interviewing and goal setting and how do you support that? And the amazing piece is, Dr. Nielsen, our consulting psychiatrist, is an amazing educator. And so part of her role has been like, hey, during your next contact, could you get this information? Or could you check in on this? And so it's this very collaborative relationship. But if Julie was here, she would share, this is one of the first times professionally she's worked with a team member with a bachelor's degree, right? Like previously it had been more psychologists, social workers, other psychiatrists. We're also the PGY3 UW psychiatry, community psychiatry rotation. So we're training future psychiatry residents on these different models of integration because we're not going to hire our way out of the lack of psychiatrists. It's about really how do we leverage their skills and knowledge in a different way to support population health. And so for me, I think that is the biggest piece. The challenge has been how do we break down these barriers of which model is superior versus instead saying like, how do we leverage the strengths of both to really meet the needs of our population? And then how do we also be open, I think, to this perpetual learning, right? Like this has stretched me in a different way, which is exciting. And then just a logistical piece, just the registry builds and some of the way you bill and you code. Dr. Wells, I don't think is on here from UW. Dr. Shanda Wells is amazing. And Access is very fortunate as an FQHC that we're on UW's Epic platform. So I didn't have to build these things from scratch. I was able to leverage the things that were created on the UW side. But the issue is UW is not an FQHC, right? And so there's different rules in how you bill things out in FQHC or a rural health clinic related to Medicaid and Medicare. And so how do you make sure people know those rules, that your charges go out clean, and that you get paid for the work that you do? And so I didn't necessarily envision myself meeting with a revenue revenue cycle every month like I do, but I do. And we look at what was denied and why, and oh, did it have this T1015 code that it needed that flagged it that this occurred in FQHC land? So I do think those are the kind of things, if you're a leader, that's important that you get in the weeds about, because you want to make sure that the systems in place to automate your billing and all of those things are actually doing what you think they are or what they're supposed to.
I'd like to second that importance of getting the ability to meet with your revenue cycle team, especially on like a monthly basis, to take a look at those. So important. And I know a lot of organizations have trouble with that buy-in. You know we need championship at all levels. I think you provided some great examples of the way we can leverage team members in a synergistic way, while also recognizing, we have to overcome these competing priorities, experiences, ideologies, misalignment with care environment. Great examples there.
Laura, can I just add one really quick thing with this?
Go ahead.
I also think this is about workforce development, and it really excites me because this is one of the first times we've actually been able to develop in-house pathways for opportunities for growth. And so actually both of my care managers right now are in part-time MSW programs, which is amazing because then their goal would be finish school and we have a social work fellowship. And so then they might do the fellowship with us and then we hire them. And so of my 12 BHCs right now, 9 of us trained and stayed at Access, myself included. And so I think that's another piece when we think about how do you introduce to integrated care and then how do you train to retain to build your workforce, because the workforce piece is so crucial to being able to have these like well-functioning teams.
That's been one of the complaints too about integrated care. Where do you go from here? Where's sort of like the career growth? So that's outstanding as another example of the importance of how we utilize team members. Cody, I'd like you to take the next one. So what are some of the core components that you've had for your workflows, and what went into creating those?
Yeah. So, when we first got started, we just jumped in and started helping kids, right? We were just like, we showed up in clinic and, the physicians were like, what exactly are you doing here? Because there was a group of us that were hired to come in and build it. But, in a big system, building it was building it as we flew it, So we stepped in and we started working with them and started to figure out like what worked and what didn't work. When could we go in? When could we not go in? We started piloting some kind of universal prevention visits and the well visits, as well as some targeted. And we just kind of spent some time, I think, figuring it out. We knew a lot of us were trained in kind of the PCBH model or a version of it. And so we were coming in with those principles in place, but just kind of feeling it out and trying to figure out, what is going to work for our system. Because I think the thing that we learned quickly is that we didn't want to start with a solution, right? I feel like you quickly end up feeling like a salesperson when you do that. Hey, I've got the solution, it's going to fix your problem. Versus we wanted to understand our providers' needs, our systems needs, and our community's needs. And we wanted to build a model that met those needs, kind of using the components that we knew existed and all the great models that exist out there. So we just started adding one at a time. So we knew Healthy Steps was not something that we wanted to do because we didn't have the capacity to be in every single well child visit from birth to 5. But we knew that in those early childhood well visits that there was a lot of need that was happening. So we developed a system where we could be part of those visits as needed, kind of on a secondary prevention or tertiary prevention kind of level. And Dr. Ty Snyder laid a great paper on that's out there from that work. And then we started realizing that, our depression work was a little messy. We weren't following up, we were dropping kids, and we said, gosh, CoCM has some really great procedures and components to keep track of these kids with a registry, with care managers who could check in, because we were losing a lot of kids in between visits, starting kids on SSRIs and they disappear on us. And so we started saying, okay, well, this is the problem that we're experiencing and which model has a good solution for that problem. And then we pulled a lot of those CoCM elements back into our care, to our depression pathway when we built it out. The depression screening and figuring out who needed to be seen and prioritizing patients, tracking them in the registry, reaching out beforehand, setting targets for treatment to target. That was extremely helpful to start maximizing the care for our patients suffering from depression. And then we figured that out with ADHD too. And then we looked around and that's just kind of what we keep doing. We kind of developed our generalist model. We figured out what our physicians needed help with on the day-to-day. We figure out how much capacity we have. And then we start adding, we start finding the problems that continue to exist and pulling other things that would help us build it. For example, Dr. Ty Snyder also convinced me, she leads our internal work. She brought me along kicking and screaming the whole time to do autism evals within our integrated model, because I was like a PCBH purist at heart. And I was like, I did not go into primary care to do psychological assessment and write reports, right? This is not what I wanted to do with my life. But here's the thing. We were walking into rooms left and right with 2-year-olds who are screening super positive on the MChat. And we're like, well, this kid will be diagnosed in 2 years. Then they'll wait on a wait list for a year for ABA treatment. And then 3 years down the road, these kids are going to end up getting the treatment they needed right about when the window closes for when we know we can make a huge impact on their lives, right? And we just kept seeing it happen over and over again. And we just couldn't tolerate it, stomach it anymore. So we called all the child development boards and ABA service providers and the insurance companies and said, what is the minimum you need for this diagnosis to count and for them to get services? And luckily, they had the ADIR on the list, which has a toddler algorithm. So kids who are younger than 4 with less than 5 words, you can do a 20 to 30 minute diagnostic interview that counts as a gold standard. We did the CARS, the ASRS, and the CBCL as well. And it fit our PCBH model, right? They're interruptible sessions. They're 45 minutes long. We can do it in 3 to 5 sessions easily. In fact, we usually do it in 2 to 3. And so it met all the criteria of our model. We have a templated report that meets the standards for ABA and everybody else. And so what we did is we defined a segment of the population. It wasn't every kid with autism, but it was kids under 4 who had very clear symptoms of autism, who needed that diagnosis and plugged into treatment quickly. And so we built out this kind of assessment pathway. It also allowed our psychologists to kind of differentiate and use the things that they could do that other folks couldn't do within our system as well, like our master's level co-located therapists. And so because our boards wouldn't allow them to do the assessment. And so we were able to step in and do that, but we fit it within the PCBH model. So I think that's our approach, is we look at our population in our clinic, we identify a problem, and then we go to the different models that exist and say, who has a tool within that model that could help us solve this problem for our patients in our system? And then we implement it, we test it, we do really tight quality improvement and implementation science with it to make sure that it is working in an ideographic way. You know, we realize we're taking components of things and that you start to stray from the evidence when you do that. So what we do is we do a lot of programmatic and ideographic assessment to make sure that it's working in the ways it's supposed to work within our system.
I think that's really helpful, regardless of what level of implementation and sustainability different teams are. You know, this idea of your approach has not really been a boilerplate approach, but more so starting with that core population, identifying the need, what's needed day to day in particular, and having that CPI, that continuous process improvement approach. It gives a really nice framework for teams that are at different stages. Beth, can you take this question next as well? So what are some of the core components to your workflows and what went into creating those?
Yes. This is a big question because it really depends on which route, right, you're going. And so I think for us, like our PCBH workflows are just like well-oiled, right? Like when in doubt, you refer to BHC and we're addressing it. What we needed to do though was to have a really clear workflow for when we referred into CoCM, what were the main, reasons, what is the process too of, getting consent and making sure the providers, like our medical colleagues, knew what we were doing. And so I think part of the development of the workflows was just about communication and role definition. I think that is so important in all of this, is how you define the roles. I know places that have tried to do both of these models when you're the same person. You're like, am I wearing my BHC hat or am I wearing the care manager hat? And I think it gets messy really quick. And so one of the pieces in our workflows was just really clear definition around roles at the outset, who is doing what, and how does that work? And because the care managers were separate, the other piece was how they're documenting their time, the creation of the smart forms, who is in the inclusion criteria, right, for the registry build. And then when are you working on like a relapse prevention plan, right? And then talking about discharging people from the program. And so I think those were some of the primary workflows that we worked on. And then we just made some pretty infographics that had around what is PCBH, what is CoCM, and we educated our team members because I think this is an important piece when we think about if patients call in, right, and they're asking, my front desk needs to know, right, what we're doing with integrated care in the same way the call center needs to know, in the same way my PCP needs to know. And so if you're talking about true integration, it's ensuring the entire care team is on the same page with what your service offerings are. So I think communication was a huge piece in the development of the workflows, and then just lots of training for our care managers in how to use these smart forms, how to use these tools. And as I mentioned, I have an LCSW who's our primary care behavioral health manager who is checking in with them every other week and is doing trainings on motivational interviewing, is doing trainings and looking at their documentation. We've got standard, right, smart phrases and tools that they're using, but ensuring that we're following that. And how you loop back with that, I think, is really important because it's an ongoing opportunity for growth and development. And particularly when we're talking about bachelor's trained individuals that are doing this for the first time, it's how do you give that extra support? And then how do you celebrate the wins? One of the things I didn't share earlier, but I think is important to note, one of my clinics actually has 54% of the population that speaks a language other than English as their primary language, with the main being Spanish-speaking individuals. And so our Latinx community has been a population that we've wanted to have greater penetration into, that at times has had some stigma associated to seeing a psychologist or talking about those issues. One of my care managers is bilingual and bicultural. And so I had a patient that did not want to speak to a psychologist, had said, no, I'm not going to be referred. I don't want to do that, but was really struggling with depression and adherence, right, to sertraline and those types of things, but was willing to engage with CoCM, was willing to talk to the care manager, and to see the improvement from those touches to getting to remission was amazing, was so cool to see. And it was, again, matching the services with what the patient wanted in a way that they found culturally acceptable and appropriate, also following evidence-based treatment. And so I just think that this is another way that we can continue to leverage health equity goals and reducing disparities in the way individuals access care and receive the care that they need.
Fantastic. You know, it's that organization theory, systematic communication for our workflows, but then really optimizing and capitalizing on your individual team members' strengths to meet the individual care needs. So some beautiful examples in there of how we build into our workflows that sort of like more rigid structure, but then having that flexibility to adapt to the population needs. Janine, let's hear from you about workflows on your side.
I would just say that everything that Cody and Beth have just said is really so wonderful. Basically, in a nutshell, what I'd say is that we have our core structures that are research-based and evidence-based that we implemented and we followed. And then, as you say, we have to stay nimble. We have to meet the needs of the community and meet the needs of our patient population. And you know, and we're even though it's a population health model in Connecticut, we are still not largely population health yet. We're behind from a lot of other states, and so we don't have we have to do a lot of fee for service in order to keep everything flowing and keep our work moving forward. And so just always making sure that we're able to meet the needs of the population first and foremost is kind of where our focus is.
Yeah, keeping that alignment with what's clinically needed with what administratively is feasible state by state. You know, we're dealing with still not full uptake for CoCM codes, for instance, across all the states. So how do we adapt that to the abilities we have? Let's have you, Janine, finish up with our last question, and then we're just going to open up to the audience just to ask any closing questions and thoughts. What are your hopes or plans for future service delivery, in particular as may relate to or not to CoCM?
Yeah, it's a great question. All I can really see is what's in front of me right now. And if we were able to continue with what we're doing right now, we'd be in really good shape, because if we all get really good at these models of care, we've really changed trajectory for hundreds of thousands of people. And so really being about the rising risk population, of course, we have high risk population. We've built how we often say it is we've built a sick care system versus a healthcare system. So if we can continue to keep our focus on how do we get more and more preventative, how do we bring psychiatry resources in sooner, how do we educate primary care providers, on not to be afraid of our patient population, and to work with our patient population, and because the majority of patients are already coming to their locations. And so that's what I would really like to see, is that we're always working toward, ending the stigma that if an illness happens in this particular organ versus any other organ in the body, that it means something different about a human being. It really doesn't. It's just an illness. And so how do we, really normalize the work that we're doing?
Yeah, how can we move from being reactive to being more proactive? And I think that's one of the great things CoCM does, is that it allows us to have mild, moderate, and severe intervention. That point about sort of how far can you look into the future, it is really helpful to kind of look at what you have now, because sometimes it's hard to, with all the different moving parts, see where that's going. Cody, why don't you answer next, and then we'll have Beth finish us out with this question.
Yeah, actually, I saw Kimberly post this in the chat, which is great because that's exactly where we were going to go too, which is that, like, how do we grow our model to include things like peer support, including in adolescence? A lot of countries have had really good success with robust peer support programs, and it's something that I think is probably going to be becoming more and more involved within our integrated models, and something that maybe hasn't been focused on a lot within our integrated models. How do we get peer parent support, and how do we get adolescent peer support to help support some of these needs? And what does that look like when that gets integrated and incorporated? And then one of the other things is we often talk a lot about like, when do we grow our model, and when do we stretch our model, and when do we build, right? And so I think some programs that I consult with struggle too, because they just keep stretching that one provider, and this provider is doing co-located therapy, and they're doing PCBH, and they're doing CoCM, and they're trying to do healthy steps at the same time, and it just becomes, every program ends up getting diluted. And so I think knowing when you stretch a little bit, like our PCBH program could stretch and handle some of these autism assessments, and we did the math to make, like, napkin math to make sure that could happen. But sometimes you have to grow, and that's why we hired these co-located therapists, part of our model too. And I think knowing when to build and when to stretch, I think, is really important, and making sure that you're thinking that through. And so I do think this kind of parent approach is this kind of parent mentor and peer mentor in adolescence is a place to build for us. I think building out in that way, it also helps with some of the I think community and cultural understandings too, where we can pull people from the community who know about this community, who are reflected by the patients that we're seeing and reflective of the patients that we're seeing, and get some of that kind of cultural understanding and match in there is going to be helpful for our system too, because I think there's a ton that we can learn from them to improve our care, as well as have them help us deliver good quality care. So I would say, like, knowing when to grow it, build, and when to stretch. And I think for us in the future, we're really trying to figure out how we pull in some of those community members and peer members to be able to help support and grow our programming.
Yeah, there's been a lot of focus on the clinical roles. So how can we start to bring in these non-clinical but really important community supports? And that lateral versus vertical growth is a challenge for all of us, right? Like, how can we preserve and make sure that we can retain our staff? And then where can we kind of build both within the clinic as well as outside? These are challenging things. Beth, what are your thoughts about this? Hopes and goals for your team?
There's two areas where this really comes to mind. One that we're actually in the process of right now, which is offering LAIs, or long-acting injectables, within primary care, because we have many patients that have more severe and persistent mental health conditions that actually have been relatively stable, right, on an LAI, but that have lost their psychiatric prescriber in the community. And historically, other places have then switched them to an oral. However, we know there's a reason they're on the LAI. And so what we'd like to do is to be able to support ongoing stability, right? When we're talking about that. And so if we didn't have the care managers that we have, the nursing team that we have, the consulting psychiatrist on our team, our PCPs would have said, no way, right? Like, there is no way we would do this. There's no way we would touch that. We don't feel like that's in our scope. But instead, our providers were like, I can do this if I have a plan. And so the plan for us is we request records. They're referred to BHC. We schedule them with the consulting psychiatrist. Dr. Nielsen does an AIMS evaluation, which is the Abnormal Involuntary Movement Scale. She green lights their prescription for an ongoing injectable, and then they come in and they see their medical provider and the nurse, and that's what happens on a monthly basis. And we've had some patients just have immense gratitude for that, because there was a lot of anxiety around, how am I going to continue to have access to this medication that has been so important to my ongoing stability and my wellness. So I think that's one area, but that was a big stretch. And as I mentioned, I've been at Access for 15 years, and we'd always set this boundary, right? Of like, nope, that's not in primary care. Like, that's not our scope. But when community access changes and the needs of your community are telling you like, hey, we need this, to Cody's point of like, when do you stretch, right? Like, when do you say, well, maybe, well, what would we need, right? To do that, and to do that safely, and to do that well. So I think that's one area. The other was the what I shared during our last meeting related to the general BHI code, and that 20-minute care management code that was just approved in Wisconsin by Wisconsin DHS in February of 2024. We are having active meetings right now about a separate smart form because they don't want me to use my CoCM form because of the automated billing that's set up with that. They're like, don't do it, Beth. So I'm going to listen to my billing and coding friends. But it's a game changer because it's the 20 minutes versus in FQHC land, right? The 60 minutes within CoCM. And there are many populations that we're planning to use this for. And so I've been meeting with our chief medical officer and our nursing team to talk about how do we scale this. And so there's going to be kind of 3 phases. And I'm going to share what those are just as other people think about it. I think some people and their states already have this approved, some do not. But work with your primary care association. I know Molly Jones is on here from WIPCA, the Wisconsin Primary Care Association, because the advocacy moves things. And basically we were told, like, we didn't approve this the first round when we approved the CoCM codes initially because we didn't know how you'd use it, right? And so it's that advocacy of understanding why it's important. And so we're going to first roll out this care management 20 minutes a month for our patients that receive LAIs, right? That I just mentioned, that our nurses are calling and saying, you're due and come back in and how are you feeling? And then also our patients that are on Vivitrol for an injection, right? Related to substance use. So that's phase 1. Phase 2 is going to include anybody within our organizations that's receiving medication for opioid use disorder, particularly BUP, because right now we have about 250 patients on buprenorphine to support recovery of opioid use disorder. And then the third areas we're talking about is greater partnership of a BHC for care management work within our OB medical home and for our patients during prenatal care and obviously in the postpartum period. Most recently, we've rolled out universal screening of moms during well child up to age 1, where before it stopped at 3 months. I was like, really? Most postpartum mood disorders are going to flare not during that time frame. And so that's another area, right, that we're thinking about the care management and the outreach. And then my chief medical officer, if there is a phase 4, really wants to talk about how our population health teams that are doing more outreach and management for chronic physical health conditions that often have a comorbid behavioral health condition that is impacting their ability to engage in self-management. How could we potentially leverage this code as well for those increased outreach and touches? And so really thinking about until Wisconsin's in a value-based payment, right, methodology, how do you leverage these codes in fee-for-service, in these other ways that really captures the value of the work that you're doing to allow a fiscally sustainable way to grow our teams?
Great examples, kind of bringing in what Janine had shared of sort of capitalizing on what's in front of you. And these are great examples of how can we best meet the needs of the community and the population, meeting them where they're at now, with also kind of bringing in new elements. Excellent examples. We could probably go another hour, but we are at the top of the hour. Any final questions? I know we've got great things in the chat. Thanks so much for panelists answering questions in the chat as well.
This is Stacy. Beth, would you mind if I try to connect with you at some point? I've been trying to move those codes. I'm in Maine, trying to share the information on those codes and move it a little bit, but hitting some barriers. So it'd be great to just hear more, learn more, so I can help educate more here.
Happy to connect offline. So if I will direct you my email, but I know Molly Jones also just attached the long form policy recommendation that WIPCA and Access collaborated on that I think is great. So that is in the chat box that I think could be really helpful. And then Molly, aren't you presenting with Sashi at the upcoming spring conference for CFHA related to some of these topics?
Yes, we are. We're talking about primary care associations and the role that we can play in advancing some policy recommendations, particularly for Medicaid, accelerating some integrated care codes. And so this is one example of the general BHI code. I say it's long form because this was us trying to just package everything into one place, but there was plenty of conversations that went alongside of it. But I think, Stacy, in particular, the framing of what will move your Medicaid, like ours was, saying that how important this was in adding to the collaborative care model, even though we know many health centers who don't have psychiatrists will be using the general BHI code just on its own without the CoCM model. But that was the framing that I think moved us over the hump in Wisconsin. So I hope that's helpful, and I'm also happy to talk offline if and as you're looking to strategize on how to move Medicaid in your state.
Awesome, thank you.
So helpful, and wanted to put in another plug for the virtual spring conference. If people haven't signed up and registered, a lot of opportunities for that. Dr. Nielsen will also be at that Beth was talking about. She and I will be running a consulting psychiatry module, and there's just such a really nice lineup of agenda items on there. All right, any final questions? Thanks so much to our panelists. This has been just a really rich discussion. And, like I said, we could go on for another hour from here. This is just the start. So connect in between. Feel free to connect offline, connect on Basecamp, email. This is how we build our community and really support each other in this excellent work that we're doing.